Okay, so the last thing we're going to talk about in this section is termination of pregnancy. There are, in these rooms, in these classes, there are varying beliefs about the morality of termination of pregnancy. We understand that. I know that we live in a very conservative part of the country. And so I know that a lot of people have very strong feelings about termination of pregnancy. What we're going to talk about today are the medical facts, and we'll touch on some of the ethical dilemmas involved. But one thing I need you to understand is that whatever your beliefs about termination, other people hold beliefs just as sincerely that are counter to yours. And so we're going to talk a little bit about that. We categorize termination as elective or therapeutic. Okay, this is a little bit different from categorizing surgeries as elective, urgent, or whatever, because elective surgeries can actually still be medically necessary. But when we categorize termination, we talk about elective or therapeutic. A therapeutic termination is done because of some threat to the health or life of the mother, typically. Therapeutic terminations may also be done if the fetus has an anomaly or condition that is not compatible with life, or that would lead to what the family considers to be excess suffering. Elective termination or all other terminations done because typically because the patient is not in a good place for pregnancy at that time, or is choosing not to be pregnant at that time. In some states, individual providers are allowed to refuse to participate in terminations. A1 supports the nurse's right to choose whether to participate in abortion procedures in keeping with their personal, moral, ethical, or religious beliefs, but states that nurses have a responsibility to inform employers of attitudes and beliefs that may interfere with job function. It is our right to refuse to participate in abortion or in terminations. It is unethical to refuse to provide care to a patient who has had an abortion. So all of that to say, if you believe that you cannot in good conscience participate in a termination procedure, you have that right. You don't have the right to work at a location where that's going to be part of your job duties on a consistent basis and then refuse to do the job. So you shouldn't go to work at an abortion clinic if you don't believe in abortion. But you do have the right to refuse to participate. You also have a responsibility to let your employer know that you cannot participate in terminations. Abortion is currently legal, although that status is more tenuous. There's actually a case, I believe, that is going to the Supreme Court soon. So the legal status of abortion may change very soon. States have different regulations. There are states that try to minimize or control abortions more. There are states that have no laws restricting abortions. It is already the case that Medicaid funds cannot be used to pay for abortion unless the woman's life is endangered. We hear frequently that Medicaid is used to pay for abortions. That's actually not accurate unless the mother's life is in danger. If the woman's life is in danger, Medicaid funds can be used to pay for that therapeutic abortion. You also should know that later term abortions are more likely to be therapeutic. Most elective abortions are in the first trimester. With increasing abortion restrictions, however, more and more women who choose elective abortion are having a hard time getting that, and so those are being pushed to later into the second trimester in some cases. So later term abortions are more likely to be therapeutic. So general care in assessing and caring for a patient who is having a termination, you need to know general health history and assessment, because you need to know what health conditions that patient may have that might increase the risk of complications. You need to know the gestational age of that pregnancy, and that's really important because gestational age determines what is the safest method of terminating that pregnancy. A second trimester abortion, an ultrasound should be done to determine gestational age and development, because that's going to impact the type of abortion that's needed, the type of procedure that's needed. There are states that require an ultrasound be showed to the patient prior to abortion in an attempt to dissuade them from having an abortion. That's not the same. This is for medical reasons. This is because in the second trimester, the stage of development of that fetus is going to impact the safest method of abortion. If the woman is Rh negative, they should receive RhoGAM within 72 hours if they're not sensitized. Okay. And we need to make sure that they understand what their options are, that they understand the risk of the procedure they're undergoing, and that they understand how to care for themselves after the procedure. The provider, as always, is responsible for informed consent, but as nurses, we frequently find patients who don't have an adequate understanding, and so we may be helping that patient understand what's happening, sometimes even calling the provider back to say, okay, I don't think this patient understands what's happening here. So that's general care for any termination procedure. In the first trimester, most terminations are carried out by aspiration. That's like a D&C. This can be done 8 to 12 weeks after last menstrual period. It's an office or clinic procedure with local anesthetic. It is sometimes done under general anesthetic for psychological reasons, especially if it's a therapeutic termination, if that patient was planning to be pregnant and the pregnancy is not viable. The cervix is dilated as necessary, and the products of conception are removed with a suction cannula. The recovery time is 1 to 3 hours. Post-procedure, some bleeding and cramping is expected. If bleeding is heavier than a period or cramping is severe, they need to go back and to be evaluated. So they need to seek assistance. Prophylactic antibiotics are common to prevent infection because infection is a risk. NSAIDs can be used for the cramping. The post-procedure teaching should be nothing in the vagina for 1 to 3 weeks. No tampons, no diaphragms, no penises, no other, nothing in the vagina for 1 to 3 weeks. We also should be giving these patients contraceptive counseling. They shouldn't become pregnant immediately after this procedure, because it would be difficult to date the pregnancy, and menstruation should resume in 4 to 6 weeks. Okay. The risk of first trimester abortion, which is usually going to be aspiration, are hemorrhage and infection. The later in pregnancy, the higher the risk. Medical abortion, or this is the abortion pill. It's actually several different combinations of meds that can be used. But medical abortion can be used up to 9 weeks after last menstrual period. So we're talking early in the first trimester. If this is attempted later in pregnancy, it actually is riskier. There are different combinations of meds that may be used, and you need to know the mechanism of action of these meds. One combination is methotrexate and misoprostol. Methotrexate blocks folic acid in fetal cells, so it stops cell division. Misoprostol is a prostaglandin that causes uterine contraction. So the methotrexate stops cell division. The misoprostol causes contractions. And so the products of conception would be expelled. The patient needs a follow-up visit to confirm completion. If it's not completed, then the misoprostol can be repeated, or an aspiration D&C can be done. Another combination is mifepristone and misoprostol. This can be used up to 7 weeks after LMP. These are both prostaglandins. It has to be used earlier. They need a follow-up visit after 2 weeks to confirm completion. If not, then they're going to need a DNC. This has a 5 to 10% failure rate. For medical abortion, post-procedure or during the process, the patient can expect quite a bit of bleeding and cramping, nausea, vomiting, and diarrhea because prostaglandins are used, headaches, dizziness. Also, prostaglandins can cause headaches, fever and chills from the prostaglandin. The risk, if it's not complete, then hemorrhage or infection can result. So if they don't completely pass all the products of conceptions, if anything is retained, then they're more likely to hemorrhage or have an infection. The risks are higher if the pregnancy is more advanced. In the second trimester abortions are about 10% of all abortions. They are almost always therapeutic. They're almost always for either maternal health reasons or because the fetus has a condition that is not compatible with life or expected to cause a lot of suffering. Dilation and evacuation can be used up to 20 weeks. It's most often used between 13 and 16 weeks. The cervix is dilated. It has to be dilated more than with a DNC. And a larger cannula is used to remove the fetus and the placenta. This is painful, increased risk of hemorrhage, and it can damage the cervix. More often later more often in the second trimester, medical abortion is going to be done. It is more often done inpatient or in a at least a clinic setting because the risk of hemorrhage is higher and because it tends to be more painful than in the first trimester. First trimester medical abortions, the people typically take the meds at home, stay at home through the process, go to a follow-up visit to make sure that it's complete. Second trimester medical abortions are higher risk, and so that's typically going to be done in a setting where they can be monitored and bleeding can be managed. After 20 weeks, induction of labor and vaginal delivery is the most common method of termination, and it's almost always for maternal or fetal illness. Okay, so that's the end of the fertility lecture. I know we ended on a really hard note, but this part of patient care can be hard at times. I will see you all in class, and we'll move on to the next.